This is a series of case examples of VEPs. We'll start with some flash VEPs in children over the age of 1, where the VEP is mature looking. This is a flash VEP in a 2-year-old girl. And in the top tracing, you can see a clear small negativity, which is the N70, and then a big positivity, which is the P100. Looking at the numbers, the N70 has a latency of 80 and the P100 of 109. And so this is a normal study. And so what should be noted is that the ERG is not very well formed or clear, but that is not relevant now because we have a clear cortical response. This is a flash VEP from a 14-year-old girl in the PICU. Now, typically in this age group, we would want to do a pattern VEP, but presumably this child is comatose or not able to sit up for a pattern VEP, and so a flash was done. And so we can see in the top tracing that there is an N70 and a P100. And so with the latencies, the technologist has written for us that it's at 75 for the N70 and 110 for the P100. So it's interesting to note here that the upper limits of normal are a little prolonged still for the younger age group. And so this child is an 11 to 14-year-old, so using the upper set of numbers, her numbers are within normal limits. If this were a 15 to 18-year-old child, then this would be an abnormal VEP. Now we'll look at some abnormal flash VEPs in children greater than 1 year of age. This is a binocular flash recording in a 4-year-old boy. And in the top tracing, it's clear that there's an N70 and a P100, which are of very high amplitude. But the latencies are quite prolonged. And so looking at what the technologist has written for us at the bottom, the N70 has a latency of 103, and the P100 has a latency of 185. And so this is an abnormal study due to delayed N70 P100. Should be noted that there's also a large and clear ERG. This is another binocular flash VEP conducted in a 3-year-old boy. And in the top tracing, you'll see there's a clear N70, but it's not exactly clear where to choose the P100. And we decided to choose the largest amplitude peak, which is quite late with a latency of 180 milliseconds. And so this is an abnormal VEP due to delayed N70 and P100. And it should be noted that there probably is an ERG. It's very low, but that's okay because there's a clear cortical response. Now let's move on to look at some flash VEPs in full-term infants within the first week of life. Just a reminder that there are extensive changes in the VEP within the first week of life to the first few months of life, till about 6 months when the VEP has a mature-looking morphology. And so a reminder that in the first week of life, up to about 4 weeks, what is observed is a P200, not a P100. And so the latency is quite long in this age group. This is a beautiful binocular flash recording in a 3-day-old term infant. In the top tracing, you'll see an N70 P200, beautifully formed, and then the big negative waveform after the P200 is the N300, which is observable in a preterm infant and not particularly relevant to a term infant. What we're interested in is the P200. And so looking at the numbers, you'll notice that they're quite long compared to what we typically see in an older child. And so even with these high numbers of an N70 at 150, a P200 at 186, these are within normal limits, and so this is a normal study. It should be noted that there's a beautiful large and clear ERG in the second tracing. And this is a binocular flash recording in a 2-day-old term infant. So what should be noted is that our clinical criteria for abnormality is latency. And so while we may look at this and think that the morphology is funny, we need to look for our waveforms and identify the peaks and their latencies. And so the N70 is not that well formed, but there is a P P200. That's what we see in term infants, is a P200. And the latency of the P200 is at 231 milliseconds, which is within upper limits of normal. And so while this does not look like the beautiful mountain that we saw in the previous case, this is a normal study for a 2-day-old term infant. And again, it should be noted that there's a clear ERG in the second tracing. Now looking at some abnormal studies of flash VEPs in term infants within the first week of life. This is a binocular flash recording in a 4-day-old term infant, and we see a clear N70 and P200, and it looks fairly well formed. But when we look at the latency of the P200, we see that's 261 milliseconds, whereas the upper limits of norms for the first week of life is 253. And so this is an abnormal study due to delayed P100. And it should be noted that there's a clear ERG that's observed in the second tracing. This is a binocular flash recording in a 3-day-old term infant. And what we see is a prominent negative peak in around the 300 millisecond region. And so that's not an N70, it's probably an N300. Now, in a term infant within the first week of life, we should start to see a clear development of the P200. And so prior to this N300, there is no little positivity that would be a P200. And so this is an abnormal study due to immature morphology. So we expect to see a P200, which we do not see. We do see an N300. And although its latency is within normal limits, we really need to see a P200 at this age. And it should be noted that it's not clear whether an ERG is observable, but because we see the prominent N300, the ERG is irrelevant because we know that the stimulus is getting to the cortex. We are now going to look at some normal flash VEPs in term infants within the first few months of life. So using this slide as a reminder, within the first week of life at term, what is seen is a P200. By about 4 weeks of age, what happens is that a earlier peak starts to form, which is the P100. And so this infant shows a little set of bunny ears from between 4 weeks to about 6 months of age, where there's a P100, P200 that is seen at about 1 month, and then as the baby matures, these two peaks start to merge with each other till about 6 months, when the two peaks have fully merged to become a P100. What should be noted is that the age of the infant is really important. And so if we see the little bunny ears at 1 year of age, it's abnormal due to immature morphology, and so we should not expect to see a P100, P200 complex at 1 year of age. Whereas if we see the little bunny ears at 4 months of age, that would be entirely normal if the latencies are normal. This is a binocular flash recording in a 3-month-old baby who was born at 27 weeks. And so now at 3 months, he's about term. And so what we see is a little set of bunny ears. There's the P100 and P200. And when we look at the latencies, they're within the upper limits of normal. And so this is a normal study for this age. And it should be noted that there's a clear ERG that we can see in the second tracing. This is a binocular flash recording in a 3-month-old term infant. And what we see is that the tracings are not very well reproduced, but we can see a first peak and a second peak. And so it's not the classic set of bunny ears, but this is a 3-month-old term infant. And so possibly these waveforms are starting to merge. And so we would call the front of the first waveform the P100 and the back where there might be a second peak, the P200. And when we look at the latencies of these two peaks, we see that they are within the upper limits of normal, and there's a clear ERG, and so we would call this a normal study. We are now going to look at some abnormal flash recordings in term infants within the first few months of life. This is a binocular flash recording in a 5-month-old boy, and there is no cortical response seen in the top tracing. However, it needs to be noted that there's no ERG response seen in the second tracing. And so without an ERG, we can't rule out some sort of eye or ophthalmologic problem. And so we can't actually interpret the cortical response. And so we would call this study abnormal due to absent cortical and retinal responses. And if we wanted, we could recommend some sort of ophthalmologic testing. This is a binocular flash recording in a 6-month-old girl. It's a little complicated to read, but we can see that there are two waveforms that reproduce really well. And so those are the two waveforms that we will use. And so in a 6-month-old girl, the little bunny ears, the P100, P200 complex, should have merged. And so if we only see one waveform, it should be called a P100. And so we have to mark the P100 where it is on this tracing. And so it comes in at around just under 250 milliseconds. And when we look at the numbers, the tech has noted that the N70 is at 140 and the P100 is at 240, making this an abnormal study due to delayed cortical responses, and it should be noted that a clear ERG is seen. We are now going to look at flash VEP recordings in preterm infants. Coming back to our chart once again, the preterm recordings are on the left-hand side, and we'll see that a VEP is obtainable in as young as 25 weeks preterm, but it looks very different from the VEPs that we typically see in older children. And so there is no P100, there is no N70. What is observable is a prominent negative downward going peak at about 300 milliseconds called the N300. At about 30 weeks preterm, another peak starts to form, and it precedes the N300 and is a small positive going peak called the P200. And so by about 30 weeks preterm, we should see a P200 and 300 complex. This is a binocular flash recording in a 5-day-old baby born at 32 weeks, so they're now 33 weeks. And what catches our eye is this prominent negativity, the N300. But what we see just prior to the N300 is a very small positivity, which we can call the P200. And so it is very small at about 30 weeks preterm. And so when we look at the numbers, they are all within the upper limits of normal. And so this would be a normal preterm study. This is a binocular flash recording in a 4-month-old born at 26 weeks. And so born at 26 weeks, now 4 months old, would make them about 2 weeks old, 2 weeks past term. And so what we expect to see is a P200 in this age group. And so the prominent positivity that we see is a P200, not a P100. And so the latency of that prominent positivity is about 167 milliseconds. The technologist has put it under the P100 column, and this is incorrect. And so that number should be moved over to the P200 column, because in this age group, where they are just 2 weeks post-term corrected, it's a P200. And so using the P200 number as the upper limits of normal, this would be a normal study for the corrected age of this child. And it should be noted that there is a clear ERG seen. We are now going to look at some abnormal flash VEP recordings in preterm infants within the first week of life. This is a binocular flash recording in a 16-day-old term infant. Now, if this were a preterm infant, this would be a very beautiful recording. But at term, we expect to see a prominent P200. And so that's not observable here. What we see is a prominent negativity, which is the N300. And just prior to the N300, we should see a positivity of some sort, which would be the P200, and it's not seen here. And so this study is abnormal due to immature responses. And it should be noted that a clear ERG is seen in this study. We are now going to look at some pattern reversal VEPs. This is a pattern reversal VEP recording in a 13-year-old girl. The top left tracing is from the left eye stimulation. The top right tracing is from a right eye stimulation, and the bottom left tracing is from binocular stimulation. In the left eye recording, you'll see 3 tracings which correspond to the left occipital electrode, mid occipital electrode, and right occipital electrode. In the right eye and binocular recordings, there are 4 tracings, and the 4th tracing corresponds to an ERG which was placed on the right eye. There is a prominent negativity and positivity in each of the tracings at midline, which correspond to an N70 P100, and we will see on the chart that all of the numbers have been filled in by the technologist, and they are all below the upper limits, and so this is a normal pattern VEP recording. Just some things to note on this chart. The technologist has told us that the patient is awake, which is nice to know because some of the high frequency noise could just be due to a little movement in the patient as they're doing the study. And then the other important thing to note is that the technologist has told us the visual acuity of this patient. And so the visual acuity for the left eye is 20/20, and for the right eye also 20/20, and this has been corrected to these numbers with glasses. This is a pattern reversal VEP in a 5-year-old girl, and again the top left tracing is the left eye, the top right tracing is the right eye, and the bottom left tracing is from the binocular recording. So first off, these recordings look a little noisy, and so it's nice to see that the tech has told us that the patient is awake, crying and moving, tense and scared. And so that patient condition would explain the noise that we see in these recordings. And so with that in mind, we try our best to find an N70 and P100. And in each of the midline recordings, there is a prominent positivity that corresponds to the P100. And just before that, a fairly clear negative dip that would correspond to the N70. And so looking at the latencies that the technologist has written for us, all the latencies look below the upper limits of normal, and the technologist has told us that visual acuity is fine at 20/25 for both eyes. And so this would be a normal study for this 5-year-old girl who is crying, moving, and tense. And now looking at some abnormal pattern reversal VEPs. This is a pattern reversal VEP in a 12-year-old girl with query MS or optic neuritis. And so the top left tracing is from the left eye stimulation, the top right tracing is the right eye stimulation, and the bottom left tracing is from binocular stimulation. And you will note that in the right eye recording, there is a prominent positivity with a corresponding negativity just before the positivity, denoting an N70 P100. On the left eye recording, however, there is no comparable waveform. There is no N70 P100 in this recording. And so coming down to our numbers, first off, we note that the patient is awake and cooperative, which is good. And so that would not explain the absence of a recording in the left eye. And when we look at the numbers, we note that the N70 P100 in the right eye is delayed. And the tech has noted that the recording in the left eye is absent, and so there are no numbers to place. And so this is consistent with an optic neuritis in both eyes, probably worse in the left as the response is absent, but also present in the right, also abnormal in the right because the response is delayed. What is very helpful is that the tech has written for us that the visual acuity on the right eye is 20/100 and 20/200 in the left eye, which means that the patient can't see the stimuli as they are in the left eye. This is a pattern reversal VEP in an 11-year-old boy with query demyelination. And so the top left tracing is the recording from the left eye, the top right tracing is the recording from the right eye, and the bottom left tracing is the binocular recording. And so in each of these stimulations, we see a clear N70 P100. And when the numbers are placed into our table, we see that all of the numbers are below the upper limits of normal. But what needs to be noticed is that there is a latency discrepancy. There's an interocular difference between the left and right eyes. And so at midline, the P100 latency in the right eye is 101 milliseconds. In the left eye, this waveform is at 111 milliseconds, so there's a 10 millisecond difference between the two eyes. And so when we see an interocular latency difference in the order of 6 to 10 milliseconds or more, even if they're within the upper limits of normal, the later eye is considered abnormal. And so in this case, the left eye is abnormal, whereas the right eye is normal. This is another example of an interocular latency difference. And so this is a pattern reversal VEP in a 5-year-old girl. The tracing on the left is the left eye recording. The tracing on the right is the right eye recording. And the N70 P100 have been marked. And so looking at the midline numbers, for both eyes, we'll see that there's a difference between the right eye and the left eye. And so the right eye has a P100 latency of 125, whereas the left eye has a latency of 111, which is a latency difference of 14 milliseconds. And so this interocular latency difference would make the right eye an abnormal test, whereas the left eye is within upper limits of normal. This is a pattern reversal VEP in a 17-year-old boy with white matter lesions. The top left recording is from the left eye, the top right recording is from the right eye, and the bottom left recording is from binocular stimulation. And so we see in both the left and right eyes a clear N70 P100, and the numbers show us that those waveforms are within the upper limits of normal. Interestingly, however, on the binocular testing, the N70 and P100 are clearly noted. The N70 is well formed, but the P100 is not so well formed. It's more broad, and there isn't a clear peak. And so we take the middle of the flattish plateau of this waveform, and so that places the P100 at about 130 milliseconds, which would make it delayed. And so the fact that we find normal results on each eye testing and an abnormal result on the binocular testing would suggest that the optic nerves are normal and the lesions are postchiasmal.